India is on par with the nations which have the highest suicide rate. And we have even overtaken China, and we have the dubious distinction of having the highest number of suicides in the world. If you take the Muslims living in Thailand or USA or UK, the suicide rate amongst them is less because Quran strictly forbids. Hindu countries and Buddhist countries have high suicide rates. Okay, because in the scriptures, in for example in Manu Shastra, which is the code of conduct for Hindus, there is a separate chapter called allowable suicides. You are allowed to commit suicide if you commit incest, if you do that. At least 20 people who attempt suicide. And every suicide or an attempted suicide affects at least 6 people around them. Why is the men who are depressed, who are probably not able to seek help, probably have difficulty in accessing help for depression? It's very difficult for a man to come and say, I'm depressed. Probably it's easier for a woman to come and say, I'm depressed. There is no single suicidococcus, like a staphylococcus or a streptococcus. Suicide is always multi-determined. There is no single simple explanation for suicide. And we always say a lot of things have to go wrong for a suicide to happen. Respected Dr. Mehru and Dr. Majid, I think after that kind of introduction, I'm almost beginning to like myself. Thank you for the very kind introduction. I came to Srinagar 40 years later, and more than the beauty of the place, I am bowled over the beauty of the people here. I have never seen such warm people whom I have never met for the first time, going out of the way to help. And it's such a pleasure to be here. And thank you for inviting me, Dr. Majid and Dr. Maghroob. We have heard so much about you, also in WHO, also for the kind of work which you have done. So it's a real privilege to be here. Dr. Majid told me that the audience is mostly psychiatrists, young professionals. And since I came in a little earlier, I was able to put together some slides because I wasn't too sure whether this is going to be just a talk, kind of a panel talk or something, but I have put together some slides and I'll see. So this is the suicide map of the world. And as you can see in this is from WHO. As you can see in this, India is on par with the nations which have the highest suicide rate. And we have even overtaken China, and we have the dubious distinction of having the highest number of suicides in the world. So, which is a very sad state of affairs. Now, if we come to India, this is the pattern which has been present for the last 20-25 years. That is, the southern states have the highest rates, the middle states like Madhya Pradesh, Maharashtra, they have middle rates, and the northernmost states have the lowest rates. Initially, we thought it was all underreporting, okay? But the million death study which I did with Vikram Patel, or even the GBD study, every study, there is a percentage variation, but the pattern remains the same. So we still do not know why the southern states all have high rates, the middle have middle rates, and the northernmost states have the lowest suicide rates in India. Such a huge variation within the country. However, the problem is enormous. This is according to the National Crime Records Bureau. We have 1,70,000 suicides in 2022. We say, even in a developed country, we say there is a 15 to 20% underreporting. So then, for every suicide, there are at least 20 people who attempt suicide. And every suicide or an attempted suicide affects at least 6 people around them. So if you calculate that, one amongst us would be affected by the suicide or attempted suicide of somebody in the next 1 year. So every 57 people, there will be one person who is affected. That is the enormity of the problem. So coming to suicide rate is, if you look at suicide rate in 1900 and to 2019, you can see the countries. Okay, before we used to say, maybe about 20-30 years ago, we used to say countries like Hungary have the highest Germany, Hungary, they are Poland, they are the highest suicide rates. But right now, if you look at it, the countries which have the highest suicide rates, the top 10 countries which have the highest suicide rates, are all in low and middle income countries, not the high income countries. It is countries like Guyana, Kiribati, Lesotho, all those countries which have the highest suicide rate. And then if you look at the male female suicide rate, in every country of the world, more number of men die by suicide than women. In every country of the world, more women attempt suicide. So this is what we call as the gender paradox. Why is that more women attempt suicide, and why is it that more men die by suicide? Is it because of the method they choose, or is it because the women are able to seek help easier because for their emotional problems, or is it because of the violent methods, whereas women generally take poisons and many of them are resuscitated? So this is a question, but this is prevalent. Again, if you look at it, if we say people who are depressed die by suicide, right? So if you look at this graph, in every country of the world, women have higher prevalence of depression than men. You can see that no, there's no country where men have a higher prevalence of depression. And then if you look at suicide death rates and prevalence of mental and substance abuse disorders, we really don't have any correlation. So we always think majority of the suicides are due to mental health problems. It may be true in developed countries, but in developing countries, we find maybe 50-60% of them have psychological disorders, but 40% is other conditions which causes. So, and if you look at the prevalence of mental disorders and substance use disorders around the world and correlate the suicide rate, you can't find any correlation. And then there is some correlation between suicides and prevalence of depression. Okay, you can see some correlation between prevalence of depression in the community and the suicide rate of the community. But again, then the prevalence of depression is higher in women, but less in suicide. But depression is correlated with suicide. So, what is it about male depression which causes suicide? Why is the men who are depressed, who are probably not able to seek help, probably have difficulty in accessing help for depression? It's very difficult for a man to come and say, I'm depressed. Probably it's easier for a woman to come and say, I'm depressed. No? So the help-seeking behavior plays a huge part. I'm not going to go into detail about what are the various risk factors for suicide, because every textbook gives you what are the various risk factors, what are the various theories, medical theory, psychological theory, sociological theory, stress diathesis model, interpersonal theory, and so on. I mean, that's a totally different thing. But if you have this slide, well, three of us with Keith Horton and Lanny Berman and all, we sat for 2 days. We wanted to bring a slide which puts all the risk factors in one slide. Every risk factor which is connected with suicide into one slide. So we came up to this where we found biological factors, what are called distal factors, then we have predisposing factors, then we have proximal factors, and then the immediate triggers. So these combine in every different way, and suicide happens. One thing we have to remember is there is no single suicidococcus like a staphylococcus or a streptococcus. Suicide is always multi-determined. There is no single simple explanation for suicide. And we always say a lot of things have to go wrong for a suicide to happen. Because suicide is not in our biology. If you look at any living organism, the basic instinct is survival. And we human beings are the only one capable of dying by suicide. There's no other living organism which can kill itself. So, is this the price we pay for our forebrain? We don't know. So, coming to, because this is going to be for many medical psychiatry residents, I thought I'll bring this in. See, we say a lot of people who have schizophrenia die by suicide. Not all the people. We normally say 10% of schizophrenics, 15% of people with mood disorder, 15% of people with alcohol use disorder end their life by suicide. Okay? Which also means that 90% of people with schizophrenia, 85% of people with alcohol use disorders, and 85% of people with mood disorders do not end their life by suicide. Right? And what is the and these diseases are long-standing, chronic diseases. So you can't be acutely suicidal for all these years, 20 years, 30 years. So we have to really find out what is this group of 10% of schizophrenics who are at a higher risk of suicide, and when are they at higher risk of suicide? That also we need to know. Okay, so people who have greater insight, we always say early recovery, early relapse, and higher functioning. Early relapse we can understand because the person feels that they have recovered, and then you have an early relapse of the psychotic symptoms, they feel they are not able to. But early recovery also, when a person recovers very quickly within a month, okay, then everybody around feels that he's okay and all the guards are left. But there is still a lot of churning going on in their brain. So early recovery. And particularly for a person who has been at a higher functioning level, who has been brilliant, who has been an IIT student, who has been doing very well, for them to realize and have a greater insight, then they have at a higher risk of suicide. And people who have depression following their psychotic episode, they have higher risk of suicide. And then when do they actually have the highest risk of suicide? Most often in schizophrenia, we find that after their admission and discharge, within the first month of discharge is when the risk is highest. First month of discharge, which means that we feel that they have become better and we have discharged them, but they are not really better, or their circumstances have not changed, or something in their circumstances has triggered something. Okay, that is the period when they are at a higher risk of. Then what about bipolar disorder? Is there a difference between bipolar and unipolar? The jury is out there. There are a lot of people. There are a lot of studies which says people who are in unipolar have higher risk of suicide because they have never seen the happy face of life. Some people believe that people who are bipolar have a higher risk of suicide because the impulsivity and aggression is a little bit more in bipolar disorder also. So they are not able to handle. So the jury is really out there. We are not able to make a decision what it is. But what we do know is that what is the time of highest risk is in the mixed phase. In the mixed phase of bipolar disorder is when the person has the highest risk of suicide. So if you have a person who is a bipolar disorder patient who has come to you with mixed symptoms and mixed phase, then you have to be very, very careful. The mixed phase is when it is very, very dangerous. Then again, alcohol use disorder. Alcohol use disorder is also a long-standing chronic condition. So when is it that an alcoholic really has the highest risk of suicide? It is not in the early part of alcoholism. In fact, alcoholism and suicide has a lot of biological components, psychological component. The association has social components. Actually, the initial period, the more serotonin is increase, and there is not much of suicide. In the last part of alcohol use disorder also, there is not risk. The risk is highest after the person has alcohol use disorder for about 10 years, when he has lost his status or socio-economic issues and other things crop up. And really, when it happens is 1 month before, if there had been an interpersonal loss, if there has been a separation from the wife, if the wife has fought with him and gone to her mother's house, or has left the house, or has issued a threat that I want a divorce, within 1 month, 80% of people who have attempted. Most of the suicides in alcoholism attempt that. What we have found in my psychological autopsy study in India is that even if you are not an alcoholic, 35% of suicides occur under the influence of alcohol. Then the other thing which is commonly associated is, of course, borderline personality disorder. But not all borderline personality disorders end their lives by suicide. Actually, people who have negative symptoms, paranoid ideation, dissociative symptoms, they have less suicide. People who are more impulsive and aggressive, they have a higher suicide. So, for long, we have always wondered whether it is an individual vulnerability which produces suicide, or whether it is the environmental factors which produces suicide. So, actually, one of my friends, Gustavo Turiki, who's the director of Brain Imaging Center in McGill, actually did a calculation and found that 42% of suicidality is hereditary from due to the biological factors, which can be low serotonin, which can be low hippocampus, which can be dorsolateral ventral issues, or networking issues, or microRNA disfiguration, and so on and so forth. But 58% is not due to biological factors. Okay. So, but both have to combine together. Okay. So, this is a really nice study, because we know that many women attempt and die by suicide, those who have had been abused when they were young. Okay. So, which is more? Family history of suicidal behavior, which is a genetic component, or child sexual abuse, which is an environmental component, which has more? If you have both, obviously the odds are higher. Okay. But if you compare only, if you go look at family history and CS, that is a group which has only family history of suicidal behavior, and a group which has only child sexual abuse, you find that child sexual abuse is higher. They have a higher odds of suicidal behavior. But again, there are a lot of biological components of child sexual behavior, because child sexual behavior has an impact on memory functioning, it has an impact on hippocampus volume, and so on and so forth, and decision making capacity. And of course, I just wanted to touch on this. We now know that more than 2 hours, every 1 hour increase in screen time increases depression and suicide by 7 to 8%. So this is the cyberbullying. You can see the effect of cyberbullying. These are meta-analysis. It increases suicidal ideation, suicidal uh, attempts, and also suicides. So 1/3 of the children are cyberbullied, and 1/3 of them are suicidal. So this I wanted to bring to this. We did this study to find out what are all the religions of the various countries and what is the suicide rates. And this has changed from 2000 to 2022. In 2000, the countries which had the highest suicide rates in terms of religion are what we call as the atheist religions. That is Russia, former countries of the Eastern Bloc, and China, and all that. Then followed by then followed by Buddhist countries, then Hindu countries, then Protestants, Catholics, last is the Muslim countries. For a long time, people thought Muslim countries is problem is that because of the strictures, it is underreported. But even if you take the Muslims living in Thailand or USA or UK, the suicide rate amongst them is less because Quran strictly forbids, and that is a very strong protective factor for reduction in suicide in the Muslim countries. So we tend to ignore the impact of religion and spirituality, and that we need to understand. Whereas if in 2022 we find that Hindu countries and Buddhist countries have high suicide rates. Okay, because in the scriptures, in for example, in Manu Shastra, which is the code of conduct for Hindus, there is a separate chapter called allowable suicides. You are allowed to commit suicide if you commit incest, if you do that. And if you look at Hindu literature, Rama, the entire Ayodhya perished by suicide. Vikramaditya died by suicide. So there are many. See, they had a dichotomous view in Hinduism. That is, individual suicides were not accepted, but religious suicides were accepted. Okay, so that was a problem. And Buddhism is kind of follow the same Hindu philosophies, so it was not thing. And then if you look at the Protestant and Catholic countries, Protestant countries had higher than Catholic countries because Catholic countries had more strictures, that it was also stigmatized and so on. Anyway, the other thing which we need to do is we have to think of three things. See, when we think of suicide and how we want to prevent suicide, we think that it was sudden. Suicide is almost always never a surprise. There are three things of suicide. One is it is an impulsive act. Okay. The two is 80% of people who are suicidal are ambivalent. They are not sure they want to die. If you talk to them, most of them would say, I don't want to die, but I cannot go on living like this. So the wish to live and the wish to die is like a seesaw battle between them. The third thing is 80% of them communicate it in some ways. Only thing is we are not tuned to listen to those warning signs. 80% have come. After the suicide, many of them would say, yeah, he told me like that. He came to me suddenly after 3 years and gave me his guitar and said, now from now on you can keep it. Things like that. So there are clear warning signs in terms of behavior, feeling, emotions, everything. Only thing is we are not tuned to that. And we also have to know that being acutely suicidal is a strong emotion. I cannot be acutely suicidal for 6 months in a year. My body can't take it. I am acutely suicidal for maybe 2 to 3 weeks. If at that time support is provided, I can come out of the suicidal crisis. If support is not provided, I may attempt. For me to pick up again to become acutely suicidal will take time. So the very nature of suicide also gives us an opportunity to intervene. If at that moment of impulse we are there, suicides can be prevented. If we increase the wish to live, suicides can be prevented. If you are able to listen to this communication, suicides can be prevented. So what is the mind of the suicidal? If you really look at it, as I said, impulsive ambivalence, and of late we have found that there is a tendency for perfectionism. They tend to be very perfect. They want everything. And there is a constant rumination for them. And we call this as Ringel's tunnel vision. In the last 2-3 weeks before they are suicidal, it's like they are looking at it like this. They cannot look at anything else. They have a very tunnel vision. There is a constriction of thought, mood, and action. Everything becomes constricted. For example, if I read a paper and I see something, somebody has died by suicide, it says, okay, that's an indication for me also to die by suicide. Okay, if you go and uh, go around and some church bell tolls, you feel it is for you. No, so you relate everything to yourself and feel that's the only way. That is called the rigid tunnel vision. We all are psychiatrists, and in a country like us with so few psychiatrists, every one of us is busy. So, to really ask the suicide and deal with it, we don't really have the time. But what we have found is that many a time we use our own judgment, and our judgment is not always perfect. Okay. So, the most important thing we need to do is to ask our patients whether they are suicidal. Somehow there is a mistaken belief among people and even amongst professionals that if we ask about it, we are introducing the thought into their mind. Okay, and that so we fail to ask. We have done this study even in NIMHANS in the National Institute. Only 30% of the patients are asked. And then the next day, when we asked all the interns to go and ask each and every patient, the suicidal ideation percentage jumped to 67%. So the failure in us is in asking. In fact, if you look at the WHO manual on suicide prevention, the first thing which says is, please ask. That's the first step in prevention. And there is no study, every study has been done, no study which shows that asking the question increases the suicidal risk. So, and it's simple, three or four questions. In fact, even this is 4 years ago. Now they have reduced it to two. Ask you, there is something called Ask You, which is developed by NIMH, which is just two questions. Ask those two questions, then you can save lives, even in a busy practice. So there are various approaches for preventing suicide. One is what we call as a universal intervention, where we intervene irrespective of whether the person is at risk of suicide or not. You do universal intervention, like for banning pesticides and things like that, okay? Banning guns, so on and so forth. Then we have what is known as selective interventions. That is, people who are at a higher risk of suicide. For example, people with mental health issues, people who have been suddenly bereaved, people who have been through trauma, everything. Okay? And then we have indicated interventions where people who are already exhibited their suicidal ideas and attempts, and what do you do with them? And we have effective strategies for everything. Okay? And so this is in our country where we have limited resources, how many we have to choose what is the best bang for buck. What is the best you can get out of the least cost. And the most important thing we have found is, as psychiatrists, what we should do is we should educate the general practitioners. Because even in our study here in India, we have found that only 10% of people who died by suicide had ever visited their psychiatrist in the previous month. But 55%, 60% had visited their general physician for a variety of somatic complaints. So, educating the general practitioners about recognizing, treating, and referring has been found to be the most effective. Then it is restriction to access to the means. We can say, how does restricting the access to the means help suicide? You can always choose another method. It is not. People who are suicidal, they ruminate about the method. So that method is very important for them. So let me tell you about something which we have done in Sneha. In Sneha, we are a 40 years organization. We are run completely by volunteers. Not one of us is paid. When we started Sneha, everyone said it won't survive. How can you run an organization for 40 years without paying anybody? But all 365 days of the year for the last 40 years, we are open. Okay. And we had to close 2 days for Chennai floods and 2 weeks during COVID because they didn't allow the volunteers to come. So we had to do procedures to have permissions and things like that. So those 2 weeks, at that time we were available on the phone. So now we have started a chat service also. Now we have about 60, 70 volunteers. We work from morning till night 2 o'clock, and everyone is a volunteer, including myself. Not one person is paid even the travel allowance. They all come on their own. To give you an example, when Rajiv Gandhi was assassinated, our volunteer was about a 55-year-old man who was about 10, 15 kilometers away. So he cycled all the way to open the center at 6 o'clock in the morning. And we had so many calls on that day. So that was the commitment of the volunteers which we had. Anyway, so we found that when the class 10 and class 12 exams were results were announced, we had calls coming, so many calls coming from students and parents. And so we, at that time, we were working only till 10 o'clock in the night. But we couldn't finish because there were so many calls which were flooding. So we decided to keep the calls open, the center open 24 hours in the month of May when all these results have come out. And the number of calls increased 3 times, 4 times. And then, in spite of that, there were a lot of suicides of exam due to exam failure. So then we did a small study and found that there were two categories of students who died by suicide. One who failed by one or two subjects by 5 marks, 10 marks. And the other was who scored wanted 90 and got 80 or something. So that fraction was small. The fraction this was a higher percentage. So with the help of the media and parents and teachers, we had a blitzkrieg of media for a week. Then we approached the government and said, we cannot allow so many youngsters to die by suicide. So after a constant lobbying, Tamil Nadu was the first government to start the supplemental exam for class grade 10 and 12. And that, you can see, reduced the suicide so much. From 500 to 100, in Chennai from 50 to 7. So Tamil Nadu government was the first government to start the supplemental exam. Following that, the other state governments have started using the supplemental exam. Our effort has been written even in the Economist that this was an initiative. The next universal intervention which we wanted to do was in terms of media reporting. We know how media can be very good for preventing suicides, can be, if a sensational reporting can cause ripple effect, weather phenomenon, and copycat suicides. So we worked a lot and we got the Press Council of India to give directions that suicide method should not be described, photo should not be there, it should not be screaming headlines. And to a large extent, at least in Tamil Nadu, we are very confident. We are very happy because any suicide story which happens in Tamil Nadu will always have helplines of government and NGOs where people can seek help. And we have also seen that there are no photographs attached. So we are able to get that with the newspaper, but unfortunately we are not able to get that with the YouTube feeders, and we have no control. Recently, about 2 months back, there was a social media influencer who um, who attempted suicide and put it on Twitter. We were within 48 hours we were able to get that Twitter removed, but by that time it had gone to YouTube, and we are not able to control the YouTube. So our government has control with Twitter. They are able to do that, but they are not able to control the YouTube. So that's a big challenge which we are facing. So coming to this, we know pesticide suicides are very, very common in our country. Quite a sizable amount of suicides are due to organophosphorus poisoning. So we developed what we call as a community storage. This is a kind of a locker system. We put it in villages in Katumanarkoil, which is south of Chennai, where each farming household has a bank locker. and they can buy the pesticides and keep it there, and it will be available for them when they need it. And we employed a person from the village to be the manager of this. Okay, so if somebody who is not a farmer, somebody who is very young, somebody who goes and gets a pesticide, then the manager will ask why. We train them. Okay, and this simple solution, you can find that those villages have become absolutely suicide free for the last 10 years. We started it in 2010. And so much so, when compared to the next surrounding villages, so much so they take pride that their village is suicide free, because the newspapers write about them, the suicide free villages, so they take pride in that. So community cohesion has improved dramatically. So this may not be directly psychological. This is not a psychological intervention. But what has happened here is you are giving time for the ambivalence to happen. For example, I remember this one man who had a big fight he came home drunk, had a big fight with his wife. And normally these villages, they have their pesticides in their home, or they bury it in the pump room, or um, in the fields. So he went searching for it. He couldn't. He remembered it was in this. He went. By the time he knew it was locked, they were not able to get it. He just slept there. And next day, the wife also felt bad, came searching for him, and he also felt. And he said, "But for that, I would have died." Now we have instituted this in 54 villages in Mehsana district in Gujarat. So this WHO has described as one of the most effective low-cost suicide prevention strategy. Then I see most of the community interventions which I have done have come from personal experience. This was a Sri Lankan refugee came to me suicidal, and he described to me the condition in his refugee camp. And he said the suicide rates are very high there, madam. Why don't you do this? So we have more than 60,000-70,000 Sri Lankan refugees residing in refugee camps in Tamil Nadu. So we went and we developed an intervention which is called CASP, which is contact and safety planning. Okay. We selected 10-15 people from the camp, okay, gave them basic 2 days training on just to give a little emotional support, and taught them how to do safety planning. Okay. Safety planning is a very simple mechanism to prevent suicide. It has shown efficacy in reducing suicide in emergency settings, in other settings. So we developed this. So this is the safety planning card. Okay. So we did this, and at the end of 1 year, we assessed the high risk people from this camp, and this assessment was done by a different set of psychologists with a control camp where it was not done, and you can see the difference. Now this model has been proved to be so good that UNHCR has taken up this model, adapted it, and is using it in all the Middle East countries now. Peter Wintervogel has adapted it, has developed this, and made it into a toolkit. And many of the refugee camps in Syria, Lebanon, and all these people are using this model now. So now coming to more psychiatric thing. See, what are the strategies which have been found to be useful in psychotherapy, which has been found to be useful for suicidal people? Cognitive therapy has been found to be useful. Yes, we have evidence in 6 months there is a reduction in suicidal ideation. But what happens after 12 months? It goes away. Okay, it is not so effective. Okay, the only effective therapy which has been found to be useful is DBT, for specifically for borderline patients, and DBTA for reducing suicidal attempts in adolescents. Nothing else has been found to be useful. Before they were talking about ABFT, but the meta-analysis doesn't show attachment-based family therapy to be useful. So then, what about drugs? Lithium over the years have found to be that it does reduce suicide. Though all of us are prescribing sodium alprovate now, there is no indication that sodium alprovate reduces suicide, whereas every indication shows lithium is protective. Even if you're, the best thing about this is, even if it is not in the therapeutic range. So if you have a mood disorder patient, if you have a mood disorder patient who has a family history or a history of an attempt, low dose of lithium is much more effective than compared to sodium alpropate. Okay, and this is a thing for all the antidepressants. What are the antidepressants? How are they effective? By and large, majority of the antidepressants are effective. Not they do not reduce suicidal ideation. They have no. You can see here. They have no. It does not reduce suicidal ideation. They have no impact on suicide attempt. But in death by suicide, they do prevent death by suicide. It does not reduce suicide attempts, but it reduces death by suicides. And if you look at the various antidepressants, I think if any one of us have a suicidal person who's depressed, try not to prescribe mirtazapine or venlafaxine. That has been associated to have more. For children, fluoxetine, but now, if any SSRI, when you give in the early stages, there will be an increased suicidal risk. So you have to, because of the increased anxiety, so you have to buffer that for 2 weeks. But for children now, though fluoxetine has more number of studies, now people say escitalopram milder doses is much better for even children and adolescents. Okay, and it is also good for uh, and this analysis is including paroxetine and excluding paroxetine, because paroxetine was the one which got started with the black box warning. And again, clozapine. It has reduced suicide among schizophrenia drastically. Before, we used to say 10% of schizophrenics die by suicide. Now it is only 6.7%. And mainly because of the introduction of clozapine. Again, so much so, there is a current research RCT going on whether in a schizophrenic patient who has a family history or has had suicidal thought or suicidal attempt, you don't have to give therapeutic doses. Just 50 milligrams of clozapine, is it enough? As an anti-suicidal drug, not as a uh, anti-schizophrenic drug. Is it worth it? Is what is being questioned. Of course, now we have the ketamine. Ketamine is really a wonder drug when it comes to suicide prevention, acute suicide prevention. Esketamine nasal spray has the maximum impact, but unfortunately we don't have it and it's extremely expensive. But ketamine reduces suicide immediately in the next 48 hours, in the next 1 hour, and the effect lasts for 2 weeks, by which time hopefully our antidepressants will start acting. My personal experience is intravenous ketamine, we have to be careful about giving it because it can produce a lot of dissociative symptoms. Okay, so you have to choose your patient to give it. So actually, off the label, many of us have started using it as a nebulizer. Take a small amount of ketamine, use it as a nebulizer, and it's very much under your control. You can stop the thing, and it produces, if not like intravenous ketamine, at least 75-80% efficacy. And you can avoid ECT in a lot, in a quite some people who are extremely suicidal. So ketamine is the new and it is, I would say, really a boon for when you want to handle acute suicidal crisis. And the slowly some of us are getting together and trying to compare intravenous versus nebulized intranasal. Okay, but if you have an intranasal esketamine, then that has a proven empirical evidence for that. For young people, definitely what we are having now is a lot of, we are now going into what is known as momentary ecological assessment, because the suicide is not a static phenomenon. No, it fluctuates. That's the biggest challenge with suicide. The suicidal feelings and emotions fluctuate so much with it, sometimes minutes, hours, and so on. So, and more so in young people. So, we have what is known as momentary ecological assessment to immediately tell you what needs to be done. And we have a lot of digital wearable devices which are being experimented, just to give you an idea. So, this is again a very simple thing which can be done even in a busy outpatient setting. Develop a safety plan. This will take you, even if you are busy, for you to teach your residents or for you to teach um, your nursing staff or a psychologist. It will take only half a day or 2 hours. Okay. I have taught safety planning to common lay volunteers and it's very effective. See how does it help? Because majority of the people who are suicidal feel that they can't control anything. Things are moving beyond control. This safety plan gives them a feeling that they can control. They can handle it. They can accept it. They can do it. So many of them keep it in their pocket. And every time when you visit next time, ask them, have you used it? Then you notice it. Even you don't have to break suicide assessment. Have you had the last, between your last visit to this visit, have you had the opportunity, did you have to use your safety plan? Did you have to look at your safety plan? That itself gives you a good marker. And now safety plan has become mandatory for all crisis lines, emergency department workers in the developed countries. And I think it is a simple strategy which we can adopt in our daily schedules. We do have a national suicide prevention strategy. We wrote the strategy in 2019, and then it was lying, and then I had to go to Delhi 4 or 5 times, and finally they put it in the website in 2021 November, and after that nothing has been done, which is a very sad state of affairs. I have tried my best, but let me come to this. See, this is called the Schneidmann's cube. Okay, so a person, that red cube, is the person who is at the highest risk of suicide. Okay, the highest risk is from, say, from little psychological pain to extreme psychological pain. Press environmental, from a positive to an extremely negative environment. And perturbation is anxiety, agitation, and all that. Okay, so the person who is in that cube is the one who is at the highest risk of suicide. So even if we cannot reduce the external press, okay, if you are able to reduce by one cube the anxiety, perturbation, agitation, or decrease the psychological pain by one cube, okay, by being a caring person, the suicide risk is that can be reduced. Okay, so I would say suicide prevention is possible by everybody and should be done by everybody.